Good evening. This is Don Sinkfield. Welcome to the Help to Adjust podcast. Today we have a very special guest. This is Dr. Candice Crawford, a friend, a colleague. Dr. Crawford is a LMHC, also a doctor of counseling psychology,
Counselor
counseling.
education.
Dr. Crawford is also a doctorate of counselor education and a professor, faculty at Capella University. Welcome.
Thank you for having me. It always feels weird when people read an introduction of someone because you just have to sit there awkwardly and just kind of listen to them.
Mm-hmm.
Thanks for having me, Don.
It is an absolute pleasure. You are a wealth of information and knowledge. Background in this, your background in this field is pretty extensive. So you did your LMHC masters at NYU, and where did you do your doctorate studies?
So, bachelor's, went to Florida State University, go Noles. Master's at NYU, PhD at Montclair State in Jersey.
Yes, and so you are in private practice now. Where do you practice, and what's the name of your practice?
Yeah. So I am the owner of Clarity and Wellness Mental Health Counseling. It's a mental health, I'd like to call it a boutique mental health practice. We're a small practice with just a few clinicians. We primarily serve women of color who've endured trauma. So we are, trauma-informed clinicians. We have a lot of clinicians who are women of color, or if they're not of color, they, identify as being a part of other marginalized communities. And I didn't mention that we're also in the Bronx, in the Riverdale area of the Bronx.
I love it. And, when you said boutique mental health practice, that is truly a great population that you serve, because many people fall into those categories of people of color, people of marginalized groups of some kind that need the services. So that's wonderful.
Absolutely.
Yeah.
That's probably what brings me the most joy. I've said that it's really I don't have children, but it's my baby. So that's something that I'm really passionate about supporting and, working with clients who really want the accessibility to mental health care, right? Because, you know me, I've actually, been a mental health counselor now for the last 10 years or so. Mm-hmm. Yeah. So it's been a long time, and I've worked in different agency settings and, worked with a variety of clients and variety of colleagues. But I was so intentional about, having something that was going to be more accessible to people who really need it. Right. And where, stigma, there's a lot of mental health stigma, and particularly in communities of color. So I really want to work to destigmatize that. So started off with a private practice. It was just me, and recognized that there was just a growing need. So I was intentional about bringing people on that could really serve that community.
Yeah. And it's great that you were intentional about it, because we need this in the community. What I've noticed is that many people who are in need of the services are highly successful people in their own right. And there is no particular group of people in terms of socioeconomic status or person of color or not, or occupations. Everyone needs this. Tell me a little bit about the population that you serve and how diverse it is.
Yeah. So, people reach out. So when I first started to get into private practice, which I honestly didn't think that I was going to do, I started to build a private practice when I was working on my dissertation. I was in the PhD program at the time. So I was doing that simultaneously. I just wanted something on the side, right? And what I have noticed is that, especially when I was working in agency settings, I was being placed with people of different, diverse backgrounds, which is great because that's something that I'm really committed to. But I really wanted to make sure that the people who needed that representation, that I was able to serve them. So a lot of my calls were Black women to be like, hey, I really want to work with you. I've been looking and looking and looking, and I can't find anyone. Or I've worked with, white folks, or I've worked with men, and I just didn't feel like I was being heard. And to me, I just recognized like, oh my gosh, I'm actually doing this work where I can actually be of support to people who want this support, and are intentional about the people that they want to serve them, right? So primarily when it was just me solo, it was probably a good 80% of Black women specifically, and then had a good number of, Black men. And then also, that I'm not exclusionary, so I don't, not work with other people, but that's just a majority of like what our population is. And then when I began to expand, I would get calls to be like, hey, can I work with you? And I'd be like, unfortunately, I don't have the space, but I have other clinicians in my practice.
Right.
And then they would be like, I don't know how to say this, but are they Black? And I'd be like, yes, absolutely. We want to make sure that we have that representation. So that's what our practice is all about.
And I always say to people, there is no way that you have to say it that you'd like to work with a clinician of color. It's okay, because I do find that people are embarrassed to ask, as if they're being quote unquote reverse racist or something.
No,
but
because we don't have a problem with saying like I want to work with a woman sometimes, right? Or I want to work with a man. Or sometimes a lot of clinicians or potential clients will say I want to work with someone who's a bit older or something. So we have no problem identifying those identities, but when it comes to they whisper on the phone, I'm like, it's just me and you. They'd be like, are they Black? So, and I'd be like, yes, don't worry,
yeah. And so you're working with Black women a lot, and what are the major issues that you're working with?
Sure. So when I say trauma, I think, trauma runs the gamut. It's a, big umbrella of issues. So, we do see a lot of, folks who have gone through childhood trauma or have experienced significant traumatic events. But then we also, work with clients who are dealing with little t trauma, right? So I'm not sure if you share with your clients about the difference between like those big traumatic events versus little t trauma, which is, those consistent, type of traumatic events that happen on occasion or happen, consistently. For example, if you are experiencing microaggressions at work, right? We get a lot of clients who are saying things like, I'm tired of being in an environment where I can't be myself. I'm tired of hearing these comments where, they say something like, why did you change your hair that way? Like just different things that happen. And I can be able to say like, yeah, girl, I feel you. You know what I mean? So that's who we support a lot. So there's a lot of significant trauma, but then also a lot of clients who are just dealing with those, little t traumas as well.
Good that you recognize that and point that out to people, because I believe that when people know about quote unquote little t traumas versus significant or, just long lasting trauma from childhood, gives the client some form of,
I think empowered. I think empowered because,
yeah.
When I'm able to say like, no, that was trauma, right? So you getting cussed out by a parent, even though you weren't physically abused, or even though you might not have, seen someone pass in a fire or something like that. You went through some traumatic events. Let's talk about that. Yeah. And let's talk about how that is manifesting in your life currently. How has that, impacted the dynamics that you have with your families, your friends, or how does that even impact your view of yourself? So we definitely talk about, I want to make sure that people are not diminishing the experiences that we've, gone through that didn't always feel good, so.
Yeah, that's good. That's really good. The word I was looking for all of that time was validation, because people really experience a lot that is very difficult for them, but there's no there's no one who will really make that very real for them.
Right.
And, going to a therapist who really has the background and understands it is important. Yeah.
Absolutely.
Yeah. So it was good that you mentioned sometimes women will come to a male therapist and they didn't feel listened to, and the connection with a woman might be stronger. Can you talk about that a bit?
Yeah, I mean, yeah, I just think it's so interesting because I think about, first, I just always say this, I'm as laid back as they come, right? So I'd like to say that I'm a laid back counselor, a laid back educator. But there's always, for me, I really, kind of like focus on how I can truly build a meaningful connection with my clients. We talk about building rapport with our clients, but I want to establish that meaningful connection. So how can we connect more about being women, right? So just before this podcast, I had a client session and we were just talking about hair, and we were talking about, she was like, girl, blah, 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 blah. And so we can be able to kind of communicate in that way, in such a way that she feels comfortable enough to talk about hair or, wigs or whatever the case may be. So it feels good to, be able to establish that connection with clients because we're able to connect woman to woman that way.
Right.
However, I will also say that just because there are similar identities in the ways that I work with my clients, so I might be sitting across from a client who, identifies as being a Black woman, my Black experience might be different from her Black experience as a woman. So, so while there is that similarity, we do acknowledge that the differences too. So.
Yeah. Say more about that. This is good.
Yeah. I mean, so I'm going to put on my educator hat a little bit. So when I teach students about, just cross-cultural work, so just because, I might be working with a Black woman, like, again, my last Black woman, she was a little bit older than me. So we talk about age. How do you feel about working with me who, someone who's a little bit younger than you or might be the same age as your daughter? Or, I might talk about religious background, right? I have a client later who, has like a different type of religious upbringing. So we talk about those things, even though we look the same, there's still a lot of things that separate us. And so I want to make sure that that's clear. I don't want to make assumptions about who I'm working with, and I don't want them to make assumptions about me either. Right. So I always kind of ask, what is it important for me to know about you? Even though we're Black women and we get each other and we can kiki and all these other kind of things, what is it that you think is really important for me to know about you? So those are the things so I love the similarities. I love working with Black women, women of color, but I also want to make sure that we highlight those differences. So that way I can truly conceptualize, their case and provide treatment that's going to be better for them.
That is so important. Yeah, I love it. And what is your top 3 diagnoses that you see?
Currently, we are seeing a lot of PTSD that, has stemmed from some acute stress disorder, but then we recognize that it's a little bit more persistent. Generally speaking, when people first come in, they present with some particular trigger. So we kind of start them off with that adjustment disorder, just so that way we can, assess a little bit more to see if there's something else that's there. A lot of major depression, a lot of that, and some other variants of anxiety disorders as well.
Yeah. So you get the adjustment disorders, and you may give that as a provisional diagnosis, but you are talking to your clients to see what else is there. Sure. What else do you see sometimes?
Yeah. So, we start to, so I want to preface this by saying, based on like my theoretical orientation, I can talk about that in a little bit. The focus is not always on the diagnosis. So this is something I also teach clients is that, I can give a diagnosis and primarily it's for insurance purposes, right? Because people can be really caught up in diagnosis. Oh, you're depressed, so you have, major depressive disorder, or you've gone through a traumatic event, so you have PTSD, and it doesn't always work out, that way. So I always try to make sure that I make meaning of the diagnosis with my client before, I diagnose them.
That's great.
But because of insurance and because of the way they, dictate a lot of things that we do, and before they can pay us, we do have to, provide that diagnosis in the beginning. And that's why I generally start with that adjustment disorder, because it does give us that wiggle room to truly assess a little bit more. So with that, with the adjustment disorder, I've seen it kind of transition into, major depression, or recognizing that maybe there is some bipolar 1 or bipolar 2 that's happening, because maybe I didn't get to see that mania, in the beginning of working with them. So it can transition into several different diagnoses. However, I always try to just like meet the client where they are and try to understand their symptoms. So that way I'm treating those symptoms and not just saying like, oh, you have bipolar disorder and that's it,
Absolutely. That's so important also, because in the same way that you mentioned that a clinician could be too caught up with the diagnosis, sometimes even clients are like, tell me what I have.
Exactly.
I just want a label for it. But truly the treatment should be holistic and based on that person, not just some diagnosis. And we say often the same thing that you said, that diagnosis is really something that we have to do, especially as it regards compensation from insurance companies. And
I think diagnoses help to provide some type of understanding, right? Like, let's say you've been struggling with something and it's just been, ailing you, and you just don't know how to name and identify. So it's nice to put names to things. But then again, like I said, I try to make sure I make meaning of what that is for my client. So that way they're just not out here walking around like I'm a depressed individual. And I also try to make sure that I use person first language, right? So, because, you'll hear people say like, oh, he's schizophrenic or he's bipolar. So I try to make sure that, they separate themselves from their diagnosis to say, I'm a person living with depression, or I'm a person living with schizophrenia, but that diagnosis does not have to define them.
it's a difference in American history between Black people saying, I'm the descendant of slaves, or the descendant of enslaved people,
Exactly.
or people who were enslaved.
Exactly.
Yeah.
And, that really plays a part in just how we think. And I think one of your more recent guests, I can't remember who it was, but you were talking about cognitive behavioral therapy, right? And so that CBT, and thinking about, okay, what are you putting in your mind when you do say things like, I'm bipolar, or I am, my descendants are, and I'm a descendant of a slave, right? What does that put into your mind?
Right.
So if we change our language to separate ourselves from that, and talking about some narrative therapy here, so externalizing that problem, right? So that way we don't become part of it.
Exactly. So the what defines for you when a person so first of all, tell us what an adjustment disorder is, so that our audience can understand it.
So adjustment disorder can be defined as, going through a life stressor that has kind of changed your behavior or your thought process or something along those lines. And that could be something, I'm not trying to minimize anything that I'm about to say, but it could be something like a recent breakup or a divorce, or it could be the loss of a job, or it can just be a change in environment. Maybe you're moving across the country, and thinking about COVID, right? I'm going to assume that all of us had adjustment disorder, right? Yeah. Because we were just struggling to navigate, through what all of that meant. And then along with adjustment disorder, like, are there symptoms of anxiety? Are there symptoms of emotional disturbances or, behavioral disturbances? Are there symptoms of depression? And so we kind of monitor that for, a few weeks, a few months. Right. So go ahead.
And so you have anxiety. You have adjustment disorder with depressed mood. You have adjustment disorder with symptoms of anxiety. And so
But that's not defining you of saying like you have major depression. It's not saying that
Right.
you are being diagnosed with anxiety for certain. It's just saying like, hey, you've gone through something that would kind of elicit some of these symptoms, so let's monitor this to see if it's something that can be manageable.
Right. And if you're seeing somebody and they're having what you see as an adjustment disorder, let's say with depressed mood, what makes the difference for you between the adjustment disorder with depressed mood and then moving into this person has a major depressive disorder?
Yeah, absolutely. Great question. So I think our DSM-5 is like our Bible in a way, right? So, according to like our DSM-5, well, let me back up a little bit. So when we think about adjustment disorder, after about 6 months or so, we want to make sure that, that person is not still experiencing anxiety and or depression or some type of other emotional disturbance significantly, right?
Right. And what's that DSM-5 that you're talking about for our guests?
The Diagnostic Statistical Manual, right?
That's right.
And then we have the TR version. What does the TR stand for again? I can't remember. But
Likewise.
It's something. So we're on our 5th version of it. And, I like it because it continues to evolve and really include lots of, just cultural changes and things like that that's happening in our society. But anyway, so after about 6 months, if we're seeing that you're still experiencing that anxiety or that depression significantly, then we'll try to assess if you're meeting criteria for other, anxiety or depressive disorders, right? And so there are lots of criteria that you have to meet before you can officially diagnose someone with, major depression or, a panic disorder or even PTSD. So we monitor that a little bit more and we make sure that that person is meeting that criteria for an extended period of time for at least 2 weeks or so to see if it's something that is worth kind of like noting as a diagnosis for them.
Mm-hmm. That's right. Thank you. And for our young people, or I should just say for audience members who may be interested in your pathway, tell me a little bit about how you became LMHC, which stands for Licensed Mental Health Counselor, and eventually a Doctor of Counselor Education that led to your professorship.
Sure. Okay, so my story is a little cliche and it could be long-winded too, so cut me off at any time, okay? But no, my story is, I knew that I had always envisioned kind of like sitting across from someone, having a person sit on the couch and me really being able to support them and like listen to them.
You knew that early on?
Like it's corny kind of. It's kind of corny because I was like reading my uncle's psychology books when I was like in the 8th grade, like. But anyway, so after, I went to school for psychology and Spanish undergrad, and then immediately thereafter went to grad school for counseling for mental health and wellness. So after I graduated with my degree, now when you get your master's in counseling, you can practice as a counselor and then work towards your licensure by obtaining hours. So I got this really great job in an agency setting here on the island, actually. And I worked there for a couple years. While I was there, as a novice counselor, I endured something very traumatic that I felt like I didn't receive enough supervision. One.
I see.
I was floored by the type of supervision that I received. And I don't think it's any fault of anybody. I just think that people are just not well trained to be counseling supervisors. So I was like, nah, this ain't worth it, right? So like I decided that I wanted to go back to school to be able to support counselors in training when they're enduring something really tough, like the death of a client, right? Or making sure that I'm being intentional about counselor development. Yeah. So just because, I have my master's and I'm licensed, there's still so much more for me to kind of like grow into, right? And so I want to be able to, impart change with counselors in training. And so that's why I went back for my PhD. So again, I did not have to get my PhD to practice as a therapist. So now I'm adding something else, right? So I went back and, learned how to be a professor or instructor rather, learned how to engage in a lot more meaningful supervision. So that's my area of expertise is counseling supervision. And that's where I landed. So again, as I was working on my PhD, I simultaneously grew this private practice.
Right.
So now I'm, dealing with the private practice and, also a professor. So it's an interesting balance.
Yeah. So bachelor's at Florida State.
Who knows?
And and your bachelor's was in a psychology related
Yes.
Field. What was that bachelor's?
It was a Bachelor's of Arts in Spanish and Psychology.
Spanish and psychology. That makes you a unicorn in your by itself. The fact that you took Spanish as a undergrad major.
And so that was helpful, particularly when I was working in a lot of agency settings and working with lots of Latino women and, supporting them. So, yeah.
You've had in New York people say something slick about you, and then they thought that you didn't speak Spanish, and then you're like, "Oh, pero."
It's happened a couple times. Not gonna lie, it's happened. Yeah.
I can imagine because you wouldn't look at Dr.
Right.
Candice Crawford and say she speaks
Right.
Spanish.
Right.
So undergrad, and then NYU for your master's, and then 3,000 hours of clinical supervision.
And then I got licensed and I said, that's it. I'm done. I'm good. I've done proved myself enough. I proved myself and everybody else like I'm good. And then, I mean, I'm not going to lie. Obviously, it feels nice to have your PhD and be called doctor, but I also wanted it to be intentional. So, which I really kind of like am a proponent of being intentional with anything that you do. So I went back to get that PhD in something that I knew was going to be meaningful, for me.
And the point that you made is very valid, that everybody who is running a practice, whether it's a private practice, state or federal funded large practice, there's not necessarily a situation where people who are supervising are excellent and insightful supervisors, even if they're good at being a therapist. And
I tell people that all the time. You can be, because in the state of New York, you can be licensed and be a supervisor with no supervisory training, really. Right. I don't know if they're changing that. I'm not sure. Other states require an additional certification for supervision. But that's something that you have to learn the hard way, that just because someone's licensed and they're a good clinician does not make them a good supervisor, right?
Social workers have the SIFI certification.
Right.
We have a few people on our team that have that, and I think it makes them better supervisors.
Exactly.
And there probably should be some training for supervision.
Yeah.
And by the way, when we talk about supervision, we don't just mean supervising people in the way that if you were working at Foot Locker, your supervisor would be just telling you what to do and instructing. In this field, supervision is having a person or a group that you can come to deal with clinical issues that you might be dealing with effectively, but have have another ear and someone who could really give you some advisement on the different perspectives and nuances of what you're experiencing as a counselor.
Right, to help like conceptualize the client cases,
Right.
to be challenged. And, again, for us as clinicians, we go through things personally, right, that can come into the room with our clients. And so in supervision, we can process that. Like, I'm really let's say you are going through a divorce and you have a client that's going through a divorce. That's tough, right? So there's going to be stuff that's going to be coming up for you. And so you need to go to supervision to make sure that you know how to handle it, right? So that's why supervision is incredibly critical. But supervision training is important too, because, we need to make sure that we know how to process those things with with the therapist. Yeah.
And it is something, because we were talking about women and how women can come to a woman therapist and get something that they can't get from a male. When I was going through a divorce, I was talking to men who were going through either a divorce or potential breakups. And a lot of times I dealt with the safety aspect, because statistically, men are more likely to explode in violence. And, possibly that situation that's happening in the home could turn into someone being harmed.
Exactly. Yeah.
And when I heard very explosive situations, sometimes I stepped out of my therapeutic mode a little bit, and I actually talked to men, like, could this become explosive? What do you, almost like the reverse of the safety plans that you hear domestic violence victims getting.
Right.
Like, is this potentially a situation where you could commit domestic violence? And if it is,
Right.
What do you need to do to either remove yourself or circumvent that?
Well, I mean, you said you came out of your therapeutic. So I feel like that's therapeutic. That's, therapeutic in and of itself too, right? To make sure that.
You're right. It is. It is.
But I hear what you mean, though. Like, sometimes you just
more like
talk to them
more like a
differently.
domestic violence.
Yeah.
Like a specialist who's kind of saying, what do you need to do tonight to not, but you're right. That is part of the therapy also. But, men particularly need to know what their limits are, and what they can and can't deal with, so they know what they can
Absolutely.
what they have to do, because it's not acceptable to become a person that's doing physical violence when, even if there's emotional violence happening in the home.
Absolutely. Yeah. So, and I think that that's why, again, supervision is so important, because when you are navigating those really, touchy waters, like, what's your plan? Could this potentially get like this? And you don't want to be holding on to that or handling that by yourself, right? So It's nice to have a supervisor to kind of like, help ground you, or to help like provide a different perspective, or just make sure that liability wise that you're good.
Right. Absolutely. And with personality disorders, I mean, it's one of the most pervasive topics now. Narcissism. There's accusations being thrown around all the time. Oh, this person's a narcissist. This person is, so narcissistic that they everything in the description of narcissism is my boyfriend, my girlfriend. Tell me your thoughts on that, and what do you see in your client base?
Yeah, so I think that there are a lot of terms that kind of get thrown around that aren't really clear. And I think we have things like social media, like TikTok, to explain, or, to blame for that, where everyone is reportedly a mental health advocate or a mental health kind of like consultant or something like that. And so they give these like really like cliche terms to like hold on to, and people run with that. So there's nothing wrong with, saying, I think that this person might have some narcissistic tendencies, but we really want to be careful about, just throwing around like personality disorder kind of terms if we are not truly understanding what that means. And because even for us as clinicians, personality disorders, like, don't officially get diagnosed until someone is at least 18, because so much can change, right? And so many things can happen, and certain people's behaviors can be exacerbated by other things. So we really need to do a full assessment. So just because you read what the criteria might be for someone who's borderline, or for someone who might be narcissist, or, and let me actually change that language. So for someone who might be diagnosed with borderline or be diagnosed with narcissism, doesn't mean that they necessarily are, just because you read the criteria for it.
There's
right?
a difference between narcissistic tendencies and a person
Exactly.
having a workup and being diagnosed
Exactly.
with narcissistic
Right.
personality disorder.
Right.
Yeah.
Right. And I think that, again, we have, I think we're all so privileged to have the access to things like Google or other types of social media where there are experts. But I think, again, because we have that immediate access, then we think that we know it all. And I'm not saying that people don't, but we just have to be careful with how we're throwing around terms, and how, we're not allowing the professionals to, truly assess, things. So.
Right. Because famously, when people look up something medical, and you go on WebMD and it gives you a quick description of whatever the diagnosis is, you say, I think I have this, because you kind of feel like you have the whole picture from this reading this brief description.
Absolutely.
Right?
But also think about like when we took like abnormal psychology or something. When we like, I'm going to speak for myself, but I'm going to probably make an assumption here for you. But like, when we took that class where we learned about all the different disorders and diagnoses, it was like, oh, I meet the criteria for every single one. I am this, I am that. And, it's, further from the truth. And so we just have to be careful, and again, there's a lot of assessment that goes into really diagnosing someone with something or providing an effective treatment plan. So, I just say take heed.
Right. Give me a little bit about narcissistic personality disorder specifically.
Yeah. I mean, I think when we think about someone who, like, especially because we are throwing that term around, is someone who has some lack of like social and awareness sometimes, right? When we think about people who are narcissistic, they focus on themselves. So they're not truly understanding what's happening around them. So there's that lack of empathy as well.
Lack of empathy.
And, the need for just kind of control in their own kind of world, right? So, and the emotional there's probably a lot of emotional dysregulation as well. So there's lots of criteria, and there's lots of criteria for narcissistic personality disorder. We also just want to be mindful that the criteria has to be met for a period of time, and not triggered or activated by a precipitating event either, right? So those are the things that we want to kind of consider.
Yeah, thank you. That's good, because the famous gaslighting term that people talk about, it's legitimate, it's real. Somebody has you questioning your own sense of perception or reality by saying that you are off, so far off, or maybe that you even started something that was precipitated by the other, right? And so you have in your mind that, if I'm being gaslit and the person seems self-centered, this is a narcissist, right? But just be clear on narcissistic tendencies, which is different from what you said. And that DSM-5 that we talked about, the Diagnostic and Statistical Manual of Psychological Disorders, that DSM-5 really explains exactly what you said, which is that period of time and the normalcy of the behavior within that person, and it happening extensively and pervasively makes all the difference between whether a person has a personality disorder
Exactly.
and whether or not they have the tendencies, which I guess you alluded to, right? You take up normal psychology. We all see some tendencies within ourselves.
Absolutely.
Right?
Oh, there are times that I'm a Leo, so I can be self-centered sometimes too. You know what I mean? But does that make me a narcissist? Perhaps not. I'm hoping that I'm not. I think I have some awareness that I'm not. But I think we have to just be very careful. So this is what I will say for those who do tend to either throw those terms around, and I'm not trying to bring anybody down or anything like that, but if we recognize that we use those terms more frequently and we are not seeking our own counseling or therapy, I would just suggest that maybe that will be, an opportunity for you to go receive that support, because particularly people with narcissistic tendencies or that personality disorder, a lot probably will not be able to change. And so it's going to be up to us how we're going to change and how we're going to react. So, if you find yourself feeling like someone is gaslighting you or someone has these narcissistic tendencies, see if you can get that support so that way you can focus on how you can react differently.
That is good advice. Get that support if you are dealing with a situation where you really believe that you're being mistreated in some way. Perhaps this person has a personality disorder. The most pervasive thing about personality disorders is that by and large, we believe from research that they don't go away, right?
And that's why that's why it can be difficult to diagnose sometimes. And so, so they might be able to change in certain environments, but, it's a personality, right? So it's not something that they probably can actively, shift. So if you recognize that you're around people like that, we want to make sure that you are recognizing why,
Right. Absolutely. This will not be the last time that we get together. This was great. Everyone, Dr. Candice Crawford, if people want to get in touch or learn more about your practice or have your social media handles.
Sure. So feel free to visit our website, clarityandwellness.com, if you are looking for in-person and or virtual sessions. Again, we're located in the Bronx, but we can work with anyone in the state of New York. So again, if you want to seek out some virtual counseling, feel free to reach out to clarityandwellness.com. Our email is hello@clarityandwellness.com. That doesn't always get to me or is not open directly by me. But if you want to reach out to me directly, you can reach out to Candice@clarityandwellness.com. That's CANDICE. And our social media handle, we're truly only on Instagram and looking to, get some social media expansion, probably with the help of someone over there. But so our handle is @clarityandwellness_ on Instagram.
All right. Excellent. Like, subscribe, and share the Help to Adjust podcast. We're on Instagram. We're on Facebook, TikTok. We look forward to connecting with you next time. Take care.